Hi guys, I'm going to do a quick review of sickle cell anemia and complications you'll often see in the hospital. I had a sickle cell patient last week and they came in with acute stroke symptoms, so I needed a refresher and maybe you guys do too. Anyway, sickle cell is caused by hemoglobin S. Hemoglobin S will polymerize under low oxygen states, infectious states, or dehydration. These red cells will sickle, they get rigid and they clog blood vessels. They also break down really fast through hemolysis, and these red blood cells typically only last 10 to 20 days compared to a normal red blood cell, which will live around 120 days. Hemolysis can cause long-term issues and acute issues. With hemolysis, you'll see an elevated LDH above 500, bilirubin can be above 3, and haptoglobin will be really low. The first complication you'll see in the hospital, the most common, is what we call a vaso-occlusive pain crisis. Sickled cells, they block the blood vessels, they starve tissues of oxygen, and this can cause intense bone and joint pain in patients. The mainstay of treatment for this is IV fluids, because this will reduce blood viscosity and allow blood to flow easier through small vessels. You're gonna want to put these people on IV pain medicines, IV opiate pain medicines dosed by the patient's history if they have a tolerance or not. And you're gonna want to monitor CBCs because if there's ongoing hemolysis going on, you might even need to transfuse these people if they're becoming symptomatic or significantly anemic. So trend the CBCs. You typically don't need an exchange transfusion in these patients unless they have organ failure. Exchange transfusion is where you take out some of the patient's sickled red blood cells from their body and you replace it with healthy red blood cells. So it reduces the ratio of sickled red blood cells in their body. Another complication of sickle cell disease you'll see in the hospital is acute chest syndrome. This one's an emergency. This can cause patients to decline or even die very rapidly. So sickled cells, they clog lung vessels and this causes hypoxia. People have chest pain, fevers, or coughs. Infections can trigger this, fat emboli can trigger it, hypoxia can trigger it. But then once they start getting acute chest syndrome, they become more hypoxic, and then hypoxia worsens the sickling, and it's a vicious cycle, vicious positive feedback loop. So you're gonna wanna get a chest x-ray. If there's new infiltrates, that pretty much confirms the diagnosis. You're gonna wanna give oxygen to keep their oxygen saturations at least above 92. You're sometimes going to want to give antibiotics, especially with the fever. You're going to want to give fluids. And if people have severe hypoxia, if they're still below 90, they're going to most likely need an exchange transfusion. So you're going to want to make sure that hematology is involved to coordinate that, so you can replace their sickled cells with healthy red blood cells. And restore lung perfusion as fast as you can. Obviously, these people may need pain meds or even more ventilatory support. Another complication you can see in the hospital is an acute stroke. So basically these sickled cells, they can also block blood vessels in the brain. This can cause an ischemic stroke, but a hemorrhagic stroke can also happen because those blood vessels in the brain become damaged and more susceptible to rupture. So if someone comes in with focal weakness or confusion, get a stat CT height or roll out a bleed, but they're gonna need an exchange transfusion. This is more important than even you wouldn't even really give thrombolytics in these patients because of the bleeding risk, but you're gonna call neurology and hematology for further guidance on that. But exchange transfusion to fix the sickled cell to normal red blood cell ratio there. Other complications include splenic sequestration, which can drop hemoglobin, and then infections with encapsulated organisms due to the splenic dysfunction. People can have like aplastic crisis, and they can also get avascular necrosis of their bone and joints. So people can have a lot of pain with this. So in summary, the labs you're going to want to check are CBC for anemia, LDH and bilirubin for hemolysis, a metabolic panel to see how the kidneys and liver are doing, blood cultures if they have a fever, Always type and cross-match them in case they need blood transfusions. You can check coags for a stroke. And I'm assuming they already had hemoglobin electrophoresis in prior diagnosis of this. And then in summary, as far as treatment goes, for vaso-occlusive pain crisis, your mainstays are IV fluids and IV pain medicines. Acute chest syndrome, you're going to want to give them oxygen, antibiotics, incentive spirometry, and oftentimes exchange transfusions. Also, with a stroke, you're going to want to call neuro, you're going to want to call heme, you're going to want to make sure this person is in a position to immediately get an exchange transfusion, check coags, and be very aware of a possible hemorrhagic stroke. For other infections, you're going to obviously want to get blood cultures, start broad spectrum antibiotics. You also have to have gallstones on the radar because the chronically elevated bilirubin can cause buildup of gallstones. So yeah, in summary, call hematology, call neurology for any stroke concerns. Hydroxyurea can prevent long-term crisis risks or reduce the risks. You're going to want to make sure these people are on folic acid and iron if they need it, although oftentimes these people get a lot of iron just from transfusions. So yeah, comment below if you have any questions. Sorry that was a long post, but maybe it was helpful.